All right. Hi, guys. Good evening. Good evening. Good evening. Welcome to another series of BLS. I hope I am audible. I'm visible. Can you all see me? Can you all hear me? Perfect. So, we'll be talking about the last topic in our discussion of the entire esophageal series. So, we're talking about the esophageal cancer today. We're talking about the esophageal carcinoma. So, today's discussion is based upon this, that is going to be our esophageal carcinoma. Now, when I say the esophageal cancers, we all understand that obviously we're talking about the histopathological variant. We'll try to understand that how it is going to develop and its so for context. Now, based upon the histopathology, I can tell that the esophageal cancers can be of two varieties that is predominantly seen. One, it is going to be the squamous cell carcinoma. Another one, it is going to be your adenocarcinoma, right? So we have two variants that you have. One, we will have the squamous cell cancer. When you're going to have the squamous cell carcinoma. Another one is going to be the adenocarcinoma. Another one is going to be the adenocarcinoma, right? So there are two variants of the esophageal cancers that you can see. One, it is going to be the squamous cell cancer. Another one, it is going to be the adenocarcinoma. Now, between these two, needless to tell you that the squamous cell cancer will be more common in presentation for a simple fact that the majority of the esophagus is lined by the squamous epithelium. Hence, squamous carcinoma is more common when compared to adenocarcinoma. Now, when you try to, reason with both of them in the context of risk factors, we'll try to analyze this. So, talk about the risk factors associated with squamous cell cancer, and then we'll also evaluate the risk factors associated with the adenocarcinoma, right? So when I say what are the risk factors which are associated with the squamous cell cancers, the important ones, number one is going to be smoking. In fact, smoking is considered to be the overall most common and the most important risk factor. Overall most common and the most important risk factor for the squamous cell carcinoma. The other risk factors that you can think about, we have already spoken about, like motility disorders like achalasia cardia. Motility disorders like achalasia cardia. You have a condition which is called as the Plummer-Vinson syndrome. We have a condition which is called as the Plummer-Vinson syndrome. We'll discuss in a short bit. Then it is associated with caustic ingestion. It is associated with caustic ingestion. Esophageal diverticulum. Esophageal diverticulum. Right? So it is associated with smoking, achalasia cardia, Plummer-Vinson syndrome, caustic ingestion, as well as esophageal diverticulum. Now, all the listeners who are down here, I would like to ask you one simple question. In which country do you think that the esophageal cancer is more dominant? So, in terms of, let's say, in terms of incidence overall, which country do you think is more predominant for esophageal cancers? But caustic injections could be both alkali as well as acid injections. Okay? Now, my question is, which country in the world is more likely to be affected with esophageal cancer? It is not what you actually think, but the underlying reason is quite interesting. Now, of course, it is the South Asian country, and among all South Asian countries, the maximum incidence of esophageal cancer, that is squamous cell variant, is more common in China, right? Okay, somebody's asking in which year should we start reading surgery? Beta, ideally you should start from the third year onwards because that's your honeymoon period. You don't have a lot many subjects to read. Start with a BLS series, one topic at a time, and by the time you reach your final year, you would have finished your surgery, and that will become a piece of cake. Ideally, you should start from the third year itself, right? But a gutka alone, or else say if you're talking about any tobacco, of course, smoking is a risk factor, but tobacco chewing will also contribute. But it is the Chinese has a very peculiar habit. I had the privilege when I went for one of the fellowships where I was an observer as well. So I had these guys who were from China, and they were also doing the observership with us. Now, one thing which is very peculiar, no matter if it was summer, winter, after I spoke to them, they told that they have this small tumbler which is filled up with water, and that is hot water. At the base of that hot water, that tumbler had a small, like a filter kind of a thing where they put the tea leaves, right? And they keep pouring the water, and as they pour the hot water, it will extract the tea extract from that hot water, and they continue to sip it. Now they sip it throughout the day, and that is one of the major reason for development of esophageal cancers, and that is nothing but long term. There is long term ingestion of hot fluids. So long-term ingestion of hot fluids is one of the major reason why a patient would develop an esophageal cancer. Hi Osama, hi Suman, hi Raj, hi Pratyusha. Good evening everyone. Hi Zuko. Great. Thank you for being a great support. I mean, you guys been there throughout our series, and the support is actually very appreciated. Thank you so much. When it comes down to adenocarcinoma, the single most important risk factor for adenocarcinoma is going to be your Barrett's esophagus. So single most important risk factor for your adenocarcinoma, it is going to be the Barrett's esophagus, right? What are the other risk factors that can contribute to this? The other risk factor is the obesity that is going to contribute along with the GRD, right? So basically the GRD that causes, chronic irritation of the esophagus, especially the lower one third, can also result it, right? Majority of the times you'll only answer Barrett's esophagus. We usually tend to miss out on obesity and GRD. Obesity and GRD are also the important risk factors for the esophageal cancer. You go back to our, the Bailey's table. It'll give you a comparison between the risk factors and their presentation. The usual risk factors they're talking about is going to be smoking. Number 2 is going to be alcohol. Number 3 is going to be your hot fluids, right? So smoking, alcohol, hot fluids. Then you have pickles, which is going to have N-nitroso containing, I would say, food which are packaged beverages, right? Or packaged food materials like pickles and all. Okay? So we have compounds containing N-nitroso, right? Then you have obviously tobacco, that is betel nut. So rather than tobacco chewing, I can contribute that to the betel nut. That is the betel nut. If you are poor, low socioeconomic status, right? Radiation exposure, does it really contribute? Again, an important risk factor to consider. Corrosive injuries, your corrosive injuries, atlasia cardia, obesity, GERD, and Barrett's. So when you open your Bailey and Love, this is the table that you'll get in the etiology. I think it is table number 66.3 if I'm not wrong. I do remember it precisely because the number looks fancy. 663, that is 66.3 is the table number if I'm not wrong, on the 28th edition of the Bailey. Now what they compare is, they're going to compare its association with that of the squamous cell cancer. They'll compare its association with the squamous cell cancer and the adenocarcinoma. Its association with the squamous cell cancer and the adenocarcinoma, right? Now, when you look at the objective, smoking is a major culprit for the squamous. It's only mildly associated adenocarcinoma. Alcohol is also a major culprit. It is actually, alcohol has no relation with the adeno. Hot fluids, again squamous, no relation with adeno. Again, we're consuming pickles, more with squamous, no with adeno. Betel nut, again, with respect to adeno, it does not contribute much. Low socioeconomic status, again, it is associated here. Radiation, when you talk about it, it is associated with both. Corrosive intake, when you talk about it, it is associated with squamous, not with adeno. Achalasia cardia squamous, not with adeno. When you talk about obesity, GRD, and Barrett's, you talk about obesity, GRD, and Barrett's. All these are associated. In fact, GRD is more strongly associated, and obviously Barrett's is the highest association that you will get. Right now, this table might look very simple to you, right? But then usually when they ask you in the competitive exam, they'll ask you what are the risk factors for the squamous cell cancer. You have all the risk factors as well as adenocarcinoma. Now, what is going to get tricky? Remember, the tricky part that they'll ask you is smoking per se is a risk factor in both squamous as well as adeno, but remember it is more in squamous when compared to adeno. Please do not forget that smoking does contribute a little bit of the adenocarcinoma. Rest, nobody is going to ask you. Remember, alcohol is exclusive for squamous. It does not contribute to adeno. Rest, you will remember it. Then is the radiation. Remember, radiation has an equal proposition, like I said, the equal predictability of developing both squamous as well as adenocarcinoma. Now, as I've told you, obesity, GRD, Barrett's, they are exclusively seen with adenocarcinoma, right? So please do not goof up with this table. Again, a very important table for us to remember from the exam perspective. Okay. Now, then comes what is this Plummer-Vinson syndrome. Now, the Plummer-Vinson syndrome, just for the quick succession. Now, if they ask you what is your Plummer-Vinson syndrome, now this Plummer-Vinson syndrome is also popularly known as the Patterson-Kelly syndrome, also commonly referred to as the Patterson-Kelly syndrome. So what is this Plummer-Vinson syndrome or the Patterson-Kelly syndrome? Let's try to decode this. Now, the components of the Plummer-Vinson syndrome or the Patterson-Kelly syndrome. Number one, it is associated with iron deficiency anemia. It is associated with the iron deficiency anemia. So it will also present to you, or the other term that they are going to use it is going to be the sideropenic anemia. So it is associated iron deficiency anemia, atrophic glossitis, upper esophageal web. Now, this upper esophageal web will present you with dysphagia. Now, if you have an upper esophageal web, do you have a lower esophageal web? The answer is yes. And that is what we call it as the Schatzki's ring. Now, when I say a Schatzki's ring, that is nothing but a synicase in mucosa due to GRD, again causing dysphagia. So, when you have a lower esophageal web, that is in relation to the GRD, whereas the upper esophageal web is in relation to Plummer-Vinson syndrome. Yes, right? Pratisha, you are correct. You have a spoon-shaped nails, and that is what we call it as the koinonchia. So, iron deficiency anemia, atrophic glossitis, upper esophageal web, koinonchia, and associated with that, there will be visceromegaly as well. So all these which are contributed together is what we call it as the Plummer-Vinson syndrome. This is what we call it as the Plummer-Vinson syndrome. Clear? Sure. Now, once you have a patient who is going to have the esophageal cancer, obviously when you have spoken about so much about squamous and adeno, we should know where will you find it. Now, when I say what is the overall most common site, what is the overall most common site for esophageal cancer? The answer is going to be the middle 1/3 of the esophagus. It is the middle 1/3 of the esophagus. If they change it to what is the overall most common site for squamous cell cancer of the esophagus, answer still remains the same. That is your middle 1/3 of the esophagus. If they change you, what is the most common site for adenocarcinoma of the esophagus? For the adenocarcinoma of esophagus, obviously it is because of Barrett's esophagus, that is seen in the lower 1/3. That is seen in the lower 1/3 of the esophagus. That is seen in the lower 1/3 of the esophagus. So overall, most common when you look at it is going to be the middle 1/3, right? If they ask you that overall most common for squamous, then it is also the middle 1/3. And if they ask you what is the most common site for adeno, then it is going to be lower 1/3, right? That is going to be your lower 1/3. So this is the data that you need to remember with respect to its presentation, right? I hope everybody is clear. I could see the screen is not that clearly visible, so I'm just going to highlight with this. Okay, so this is the overall most common site for esophageal cancer is middle 1/3, squamous is going to be middle 1/3, whereas adeno is going to be the lower 1/3 of the esophagus, right? So I hope everybody is quite clear on this. Now, how does the patient present to us? We talk about the clinical presentation of the esophageal cancer. Now, quite predictable. So we'll talk about the clinical features of the esophageal cancer. Right, so nothing, great rocket science behind it. It's a very simple presentation. You need to understand it. We'll try to decode it accordingly. Now, imagine that this happens to be the esophagus. And this happens to be the stomach. Now, let's say this happens to be the diaphragm. Now, when you divide this into context, we're talking about anywhere, let's say in the middle 1/3, there is the esophageal cancer, which is going to develop. So let's say this is the mid part of the esophagus, and consider the middle 1/3 of the thoracic esophagus. In general, talking about it, right? Okay, so you will notice that there is a lesion that is going to develop, or a tumor, which is going to be initially here. Now, as it is small, it is not going to cause any problem, but as it is going to become bigger and bigger, now as it is going to become bigger and bigger, it is going to occupy more and more space into the lumen. Now, as it occupies more space into the lumen, it is now going to compromise or make it smaller, and hence the symptoms will be pertaining to that. So what are the symptoms that we're going to expect, right? Okay, what are the symptoms? Just give me a second. Okay, the symptoms that you're going to expect, in fact, the earliest symptom, that will be presence of dysphagia. Now, we already discussed a lot about dysphagia. I'll just quickly ask you the questionnaire that is important. Now, in the dysphagia, the first question, is it going to be solids, liquids, or both? Now, remember, initially, or I can say in an early presentation, it is only for solids. It is only for solids. In an advanced disease, it will be for both solids as well as liquids. Now, our question number 2, as most of you know, that if you know is it for both solids and liquids, it is more for. The third question that you'll see, it is more for. The dysphagia will be more for solids when compared to liquids. When compared to liquids, for obvious reasons, it's a lumen which has been occupied by a tumor, so it is narrowing the space, not allowing the fluid to pass. It will be more for solids when compared to liquids. Will it be a progressive or a non-progressive dysphagia? As the tumor continues to become bigger, the lumen is going to become smaller and smaller. As the lumen continues to become smaller, you will not have enough space for the food to pass. Hence, the dysphagia will become more severe. So initially, small tumor is small, dysphagia is less, tumor becomes bigger, bigger, bigger. As you can see right across here, you'll see the lesion is now occupying the entire space. So here I can say that this is going to be a progressive dysphagia. So you have the earliest clinical feature that you will see is of dysphagia. Initially, it is only for solids. Now, as the disease progresses, it will become for both solids and liquids. Eventually, it will have that entire lumen been obliterated. But whenever the dysphagia is going to occur, it will always be more for solids when compared to liquids. At the same time, you will notice that this will remain progressive in nature. That means it will continue to become more and more. Now, what else can you expect along with dysphagia? Every time the patient is going to eat the food is going to go down here. Now, as the food goes, obviously it will not have enough amount of passes, so there is dysphagia that is going to be present. But some amount of food will get accumulated over the tumor. ठीक है, थोड़ा बहुत जो खाना है आपने खाया है वो ट्यूमर के ऊपर बैठ जाएगा और ल्यूमेन को ऑब्लिटरेट करना है तो उसके ऊपर पड़ा रहेगा. Now that food will start to revert back. So there is regurgitation of food particles. There will be presence of regurgitation. There is presence of regurgitation of food particles. There is regurgitation of food particles. Now, another interesting thing is, obviously, when the tumor is going to arise, it is going to get its vascularity. So this lesion will remain vascular, right? Now, obviously, the new blood vessels which are formed under the influence of vascular endothelial growth factors, they are very weak, friable. So every time the food goes, it brushes the tumor, hence it is going to bleed. And when it bleeds, two things are going to happen. One, obviously, it is irritating, it is going to go up and down. If the blood comes up, as we all know, this is what we call it as hematemesis. This is what we call it as the hematemesis. ठीक है, सो हमारी मूवीज में होता ना कि खून की उल्टी होती है, इसको तो कैंसर हो गया. ठीक है, एक्चुअली इंडिया में रहते रहते आपको पहले बोलना चाहिए इसको तो टीबी हो गया. ठीक है, लेकिन टू मेक इट मोर ड्रामेटिक, ठीक है, अगर मूवी दिख रहा है जहाँ गरीब इंसान है, ठीक है, गरीब के मुंह से खून निकल रहा है तो टीबी बोलोगे, अमीर के मुंह से खून निकल रहा है तो आप उसको ट्यूमर बोलोगे. ठीक है, इंडिया में 3 टी चलता है. कौन कौन सा 3 टी है? टीबी, ट्यूमर एंड ट्रॉमा. कोई भी ऐसा ब्रांच चुन लो जहां पे तीनों का कॉम्बिनेशन मिलेगा, यू विल नेवर गो रॉन्ग इन योर लाइफ. ठीक है, सो रिमेंबर इट इज टीबी, इट हैज टू बी ट्यूमर, इट हैज टू बी ट्रॉमा, ऑल 3 एट वन प्लेस, you got it, right? So hematemesis is because of the blood that is reverting up. The same thing, the blood can go down as well, so it will combine with the stools and result in development of melena, right? So you have hematemesis as well as melena. Okay. So you have hematemesis as well as melena that is going to be present. Now, any malignancy per se, it will be associated with cancer cachexia. So hence it will be associated with significant weight loss as well. It will be associated with significant weight loss. We've already discussed if more than equal to 10% of the body weight over a period of 180 days or 6 months is what we call it as significant weight loss, right? That is what we call as significant weight loss. Now, as the tumor goes through and it is going to penetrate through the wall. Now, as it penetrates through the wall, it can cause local infiltration. One of the beautiful signs of local infiltration, you have the vagus nerve and the rectal nerve, which is going to be going the tracheoesophageal groove. You remember in our thyroid lecture, I told you the rectal nerve is going to be present. When it infiltrates, it can present to you with hoarseness of voice. Now, hoarseness of voice is not a good sign in esophageal malignancies. It is associated with anorexia as well as fatigue. It will be associated with anorexia as well as fatigue. Okay. I'm not going to go into greater details where it can encroach into the trachea, causing tracheoesophageal fistulas. Malignant tracheoesophageal fistulas can also be present, where the patient can present it with lung abscess because of the food particles migrating from the esophagus into the trachea. But that's another day's discussion, right? For now, you have a patient who is going to land up to our clinic with dysphagia, regurgitation of food particles, usually solid. Then you have hematemesis, melena, significant weight loss, hoarseness of voice, as well as anorexia and fatigue. This is what its general presentation would look like. Now, when a patient lands up to you, so when you have this presentation, usual age of presentation is going to be the 5th decade of life, and it is more common in males when compared to females. So you will have an elderly male with this presentation. A patient has dysphagia. That is good enough for me to go ahead to evaluate, especially in an elderly patient. So when you have a patient who's going to present to you with dysphagia, So we'll talk about the investigations that we can do. Okay. So when you talk about the investigations that we have, right, if you're looking me making all the gestures, my daughter is here and she's trying to sneak into our studio. She wants to be in, right? So I'm trying to put her away and ask her to get some water, right? Just ignore that. So obviously when you have the dysphagia, give me a second, guys. Okay. So Adya got me water. Thank you, Adya. Do you want to come say hi? You don't want to say hi? You shy? You'll say bye? Okay, then we'll say bye. Okay. Right. So what are the investigations that we can do? Now, in terms of investigations, now patient is having dysphagia. Needless to tell you, the first investigation that I would like to do is going to be barium swallow. Now, when you do a barium swallow, what is going to happen? So this is the esophagus, and let's say this is the tumor that is being developed inside the esophagus, right? So now I'm going to fill this up with the contrast. So we're going to push some contrast into it. Now as the contrast will go in, it will not be able to map exactly the area where you are going to have the tumor. So this is how the tumor would look like on a contrast image. So if I just isolate this on an X-ray, I can only see the contrast, nothing else. So you will see that this is the contrast that is filled up. This is the contrast that you'll see, which is going to be filled up. It will go throughout. It will keep filling, but at the side of the tumor, it will be something like this, right? So you see the contrast is going to fill up, and this is the side where you see the contrast as an irregular filling defect, right? Now, this is an early phase. Now, if it becomes more prominent, you will see that it will become more narrowed out as well, right? This will become more narrowed out. It will become like this, right? So the tumor, as it continues to grow, it will become more narrowed out in this particular fashion, right? Now, as it narrows out, you will be able to point this finding, right? So you can see that it's just becoming narrow across here. I can show you a couple of images. Yes, as most of you saying, there's a filling defect that is present. Now, this filling defect that you can see, this filling defect that you can see will not be a uniform one. You will see it will be a very irregular filling defect. The margins will be irregular, indicating it's a growth that you'll see. Not have a uniform margin, you have a very irregular margin that is going to be present, right? So I'll try to show you a couple of images that we have for the filling defect. Just hold on for a second. I'm going to add it from our library. Okay. Do we have it here? No, wait. I need to put it across. Give me 1 second. Sorry, guys. Just give me 1 second. We'll just put it across. Okay, got it. Okay, so when you do a barium swallow, this is how the image is going to look like, right? So when you look at the image, let's try to decode it. You can see there is an irregular filling defect. So there's a regular filling defect that you can see. And from here, you can see there's an irregular filling defect. Now, at this irregular filling defect, you have these points. You can see these are like hunches which are present. So these are what we call it as the shouldering sign. This is what we call it as the shouldering sign. Another one, as you can see, this is what we call it as the shouldering sign. And this is what we call it as the rat tail appearance. This is what we call it as the rat tail sign. And if you look at the entire image per se, if I just add this image again, if I add this image across here again, you can see it also looks like somebody has eaten the apple and threw the apple away, right? It's like the center of the apple and the core is left behind. So this is also called as the apple core sign. So on a barium swallow, if you have a shouldering sign, if you have an apple core sign, all these indicates, or a rat tail appearance indicates an mass or an esophageal cancer. Obviously, I would like to evaluate it. I'm more keen and interested, so I'll go to step 2. That is going to be an upper GI endoscopy. So when I do an upper GI endoscopy, I will see a mass there. So hence, I will take the biopsy as well. So upper GI endoscopy with biopsy is now going to give me a confirmatory diagnosis that the patient is having an esophageal cancer, right? That the patient is now having an esophageal cancer. Now the question is, I want to know what is the staging of this disease. So I need to know, is it going deeper into the esophagus or not based upon the wall? Is it limited to mucosa? Is it going to submucosa? Is it involving the muscular, or it is going to go beyond muscular status? Now, if I say what is the investigation of choice in terms of staging? So the third question that they'll say, so I can say the upper GI endoscopy with biopsy is the investigation of choice for diagnosis. So I can just go ahead and tell you that this happens to be the investigation of choice. This is the investigation of choice for diagnosis. Now, the third one is investigation of choice for staging. It is going to be an upper GI endoscopy with ultrasound, that is endo ultrasound. It is an endo ultrasound. This is the investigation of choice for staging. This is the investigation of choice for staging. Right. So barium swallow becomes the first investigation. Upper GI endoscopy with biopsy becomes the investigation of choice for diagnosis, whereas the upper GI endoscopy with ultrasound, that is an endo ultrasound, becomes the investigation of choice for staging, right? But if I say what is the investigation of choice to look for distant spread or metastasis, so the answer is going to be your PET CT, right? So if I say what is the investigation of choice for metastasis, so we do a PET CT. This is the investigation of choice for metastasis. Now, having said so much about it, remember the most common route of spread. How does the esophageal cancer spread? The most common route of spread for the esophageal cancer, it is going to be the direct route of spread. This is the direct route of spread. Now, if it is going to spread directly, where it will go down to? It is now going to go and invade into the lungs. So, the most common site for secondaries, it is going to be lungs. The most common site for secondaries is going to be lungs. Clear? Pratyay, spot on. Absolutely correct. So all these points that I've told you in terms of investigation has been our exam question. So yes, you guys are spot on. If you know this data, it is more than enough for us to evaluate. Now, something very interesting about an endo, we call it as EUS, which we'll discuss it here. So when you talk about the EUS, EUS stands for endoscopic ultrasound. So when you do an endoscopic ultrasound, you will see multiple layers which are present. And how do you interpret that layers is going to be important. So if I give you an EUS image, you should be able to interpret its findings, right? So what are the findings that you have on an endo ultrasound? So in an endo ultrasound, total number of layers that you have is 5. That is layer number 1, layer number 2, layer number 3, layer number 4, and layer number 5, right? Now, how will they present to you? The layer number 1 is going to be, let's say, we'll use two colors. One is going to be gray and other white, and let's say we'll keep it very simple. One, I would say that I'll use a lighter color. Okay. So you'll see different layers which are present. You'll see the first layer that is going to be present, okay, which is going to be bright in color. Then you have a darker layer which is going to be present. So we'll say the dark layer, we'll use it this color. We can see blue. Can we see blue? Can we see blue? I think we can see blue. Yeah, visible. So the layer 2 will be like this, right? Then layer 3 will be bright again. Layer 3 is slightly bigger. Then you have layer 4, which is, and the last one is layer 5. This is how the interpretation is going to look like. So when you do an endo ultrasound, this is how the image is going to look like. The multiple interpretations that you can have. This is the layer number 1, this is the layer number 2, this is a layer number 3, this is a layer number 4, and this happens to be the layer number 5, right? Now, what is the layer number 1? The layer number 1 is obviously the mucosa, which is going to be white in color. The darker one is going to be your deep mucosa. So it starts as the deep mucosa, also called as the muscularis mucosa. So this is your muscularis mucosa, right? Then you have the submucosa, that is your layer number 3. Then your layer number 4 is your muscles, that is your muscularis propria. Because there's no serosa at the end, you will see adventitia. So this is your endo ultrasound layers. So when you do an endo ultrasound, based upon at what level you have the tumor infiltrate, you will be able to interpret it. I'll just show you the image for EUS also. Unfortunately, all of them are in my phone. I have to just get them downloaded and give it to you. Okay. So this is the same interpretation that you have for the endoscopic ultrasound. I'll give you another image for the same. But I have to interpret what is wrong also. Yeah, almost there. So try to superimpose normal and abnormal both EUS that you can see here. Now got two images of the endoscopic ultrasound. We can relate to both of them. See the center that you have, which you can see, this is the USG probe. You have an endoscopic ultrasound probe that is present, and that is going to have a balloon which is going to distend. So this is the edge of the balloon, right? This is the edge of the balloon, so we're not worried about it. As you can see, the first layer that is present is mucosa, then your muscularis mucosa, submucosa, muscularis propria, and adventitia. You can see in the same sequence, right? But when you see here, this appears to be distorted. How it is distorted? You can see the cancer is present here. Based upon it, say this, as you all know, this is the ultrasound probe, and this happens to be the edge of the balloon, and this is the mucosa, right? This happens to be a deeper mucosa, and this is your submucosa. You can see the tumor is now infiltrated all the way across here. So based upon the endo ultrasound, I know that how much it is going to penetrate, and I know whether it is involving the underlying muscular status or not, right? So EUS is a great tool to basically give me an idea that how extensive a particular disease is, right? So this concludes your diagnostics of your esophageal cancer. Okay. So we covered everything that is relevant from its the basic presentation across here. That is esophageal cancer. What are the risk factors? What are the differentiating factors that you have? We also learned about Plummer-Vinson syndrome, clinical presentation of your esophageal cancer, and its radiological diagnosis. Tomorrow we'll resume back at 9 o'clock and we'll look at the treatment protocol, right? So tomorrow we'll talk about the TNM classification, how do you assess the disease, what is the management protocol, what are the surgeries, and what are the different surgical methods that we have, or I can say the techniques in order to reconstruct the esophagus, right? Until then, thank you so much for joining today. We'll resume back tomorrow at 9 o'clock. Have a good time. Take care. And you know where to find us. If you have any questions, any queries, always reach us out on the channel that is the surgery guide, right? This is there on both Telegram as well as Instagram by my name, that is Dr. Sandeep Seeram Reddy. Any questions, any queries, just pin us here, both Instagram as well as Telegram, right? Thank you so much for joining. Have a good night. Take care and goodbye. And Adi, I want to say goodbye as well. Okay, come on. Say bye. Take care, guys. Good night. Have fun. Say good night.
Good night.
Sure. Bye.